Okay. Thank you, Dr. Sharifah, for the introduction. Okay, the title of my presentation here is really very broad, so I'm very glad that Debbie has emphasized to you the importance of primary health care, and because that's precisely what I'm going to focus on, which is actually primary care. So in this presentation, I aim to highlight the importance of primary care and to introduce the issues that the media can raise in primary care to generate discussions. So the flow of my presentation is I will just very quickly highlight the major health problems that we are facing now in Malaysia in the population. What is primary care? Why is it important? How is primary care provided in Malaysia's mixed healthcare system? What are the constraints and challenges in our primary care? And how can primary care be improved to address these problems? So I think I don't have to go very much into this because Dr. Chan has already explained within the last 50 years or so, 50, 60 years, we have done quite well in terms of bringing down all the mortality rates, which are indicators of population health. And the major shift in disease pattern for Malaysia has been from ill health and major causes of ill health and death shifted from infectious diseases and diseases of early infancy, and currently we are facing an epidemic of non-communicable diseases. Okay, so what are NCDs? The major health this slide is borrowed from MOH. I think it's from NHMS. And this is how NHMS presents it, is the 3+1. Diabetes, hypertension, high cholesterol, plus obesity, which are major risk factors for heart disease and stroke. How bad is the problem? Okay, I just make 3 points with regards to how bad the problem is. Number one, the high prevalence of risk factors in the population. According to one of the NHMS reports, 98% of the population have at least one NCD risk factor. Here, what they are measuring are these four aspects: drinking, low physical activity, poor nutrition, smoking. Okay? And there are, of course, people with multiple risk factors. And the trends in obesity is going up. Malaysia has the highest prevalence of obesity and overweight in the whole of Southeast Asia. Dr. Chan has also talked about this, and this is how NHMS 2023 presents our problem. How bad is the problem? Number two, at the community level, we are actually seeing people who have NCDs, but they do not know they have NCDs, undiagnosed NCDs. Okay, and this is from research from the Malaysian Health, I think it's the this is NHMS as well, I think. Yeah. So let us give an example, okay, I just have time to give one example, which is diabetes, which is one of the major problems. It is one of the top causes of death in Malaysia. 1 in 6 adults in Malaysia have diabetes. And the problem is there are also young people with diabetes. And the young people with diabetes, 84% of adults aged between 18 to 29 years of age, they do not know they have diabetes. Okay, so this is the problem of the undiagnosed diabetes. And overall in the population, adult population, 2 in 5 adults with diabetes do not know they have diabetes. So the prevalence of undiagnosed diabetes is equal or higher than diagnosed diabetes. Not only that, if you look at the years from 1986 to 2015, the graph at the top, the prevalence of undiagnosed diabetes actually increased faster, more than diagnosed diabetes. That means the rate of increase in diabetes in the population is much higher than those that actually is being treated. How bad is the problem? Number 3, the third point. Sorry, this is not 2 of 3, it's 3 of 3. Is the consequences of NCDs. And here there are 2 population health indicators that has been analyzed and shown. One is DALYs, the disability adjusted life years lost, which is loss of healthy life to ill health, disability, and early death. And the second population health indicator, adult life expectancies, which Dr. Chan has shown, they do not improve as much as they could and should. So these are the, this is a graphical depiction of the DALYs, which in Malaysia, it has increased from 1990, 60% to 71.7% DALYs caused by NCDs. So this one, Dr. Chan has already gone through this. Okay, so the next question, of course, is our healthcare system able to handle this problem, right? So the short answer is no lah. The long answer, more explanatory answer is that the existing design and the level of resources in our health system at the present moment cannot adequately manage the rising NCD problem. That's why it's not only large, the problem is not only large, it is increasing. And how do we know this? How do we know this? What's the evidence for this? Okay, I present two things. Number 1, avoidable mortality rates. Avoidable mortality rates are death rates from diseases for which outcomes could have been influenced or can be influenced by current medical services and technology. Okay? And when you compare that with other countries, OECD countries, neighboring countries, countries with comparable income indicators, our avoidable mortality rates are higher. And this is one of the comparisons. Okay, so Malaysia is right on top. Our avoidable deaths there are higher than OECD, which is the dark bar in the middle. And it's higher than Sri Lanka, which apparently spends less on health than we do. Higher than Mexico, which is also a comparable country. And in 2008, the top 5 causes of avoidable deaths in Malaysia were selected invasive infections, cerebrovascular disease, ischemic heart disease, hypertensive heart disease, and nephritis, accounting for 75% of avoidable deaths. The second indicator that we can so-called the evidence for this are the high rates of inpatient admissions for ambulatory care-sensitive chronic conditions. Okay, what are ambulatory care-sensitive chronic conditions? Conditions that should be treated and arrested at the primary care level, but they are not. And you will see these cases reaching the hospitals. So these are examples. Examples are like asthma, bronchopneumonia, infectious gastroenteritis and colitis, and also high rates of hospital admissions for long-term complications of diabetes. Okay? So this result finding is from the Harvard study. It's quite dated already. It's 2016, but I think still relevant. And it's also pointed out that the high rates of hospital admissions for long-term complications of diabetes. And diabetes is used here in this study as a tracer condition, indicates that these cases of diabetes, which should be treated and managed at the primary care level, is not being managed well, so much so that they enter hospital and they are long-term care in hospital. So in other words, the hospitals are being used for long-term care because Malaysia doesn't really have, long-term care lah. Right? Okay. So that is the problem. So the problem is when these diseases are not caught at the primary level, they reach the secondary level, reach hospitals, then it's more costly, right? It's more costly to treat because they are at advanced stages. There are more complications, and so more suffering also. It's not just money, it's also suffering, human suffering. So the important thing is we have to focus on primary care, primary health care. Okay, so I diverge, there's a divergence, I divert myself for the next 5 to 6 slides to focus on explain a bit on what is primary care. So maybe I can go through this very fast. Primary care, how the term primary care is used in relation to primary health care. Sometimes it's used interchangeably, but sometimes there is a difference. The primary care that I will be focusing on refers to the point of first contact with the healthcare system, the first level of healthcare provided at health clinics and GP clinics. So if you refer to the theories of primary care, this is very common, the 4 C's of primary care, as expounded by Barbara Starfield from 1992 to 1998, and even now recently she's still writing. Good quality primary care is constituted by 4 core functions or 4 tenets. First contact, it must be accessible, there must be gatekeeping. Number 2, it must be comprehensive. The scope and range of services must be, cover from promotion, prevention, right up to palliative. It must have the capacity to cater to a spectrum of needs along the whole life course and in the context of the prevalence of health conditions in the population served. There must be coordination, because if you just see specialists, you don't know which specialist to go to, right? You have to bring together the different elements and levels of the healthcare system for the care of the patients. So you have to evaluate the care needs, discuss, choose options, maintain communication, and failure of coordination between hospitals, private primary care providers, community-based services will lead to care that is inappropriate, insufficient, redundant, and error-prone. And 4th, continuity. You need longitudinal continuity care. You have to emphasize the coherence and connectedness of the patient's health condition and medical care needs over time. And this diagram basically shows the interconnections between the 4 C's. So why is primary care important? Because achievement of the 4 C's has been shown in studies is that it is associated with better quality services, lower costs, less inequality in healthcare, better health outcomes, greater efficiency. And it's mostly resulting from increased appropriate referrals, lower hospitalization rates, decreased specialist use, and decrease in emergency visits. And there is also research that has shown that increase in specialist use does not correlate with better health outcomes. Take my word for it, okay? It's too long to go into it. Okay, so what is, now I want to come back and talk about Malaysia. What is our current situation in Malaysia? So this is from the Health Facts. Oh, sorry, not 2003, sorry, it should be 2023. So we are talking about the government on the government side, if we talk about primary care, we are talking about care that is given through the health clinics. The total number of health clinics here is 3,114. Of these, you have health clinics, rural clinics, maternal and child health clinics, community clinics. On the private side, on the right-hand side, the primary care will be provided by the medical clinics. Now, this 10,495, unfortunately, does not show the breakdown between specialist clinics and GP clinics, okay? So this is not a breakdown figure. But there has been research, later I'll explain, that GP clinics are about 70% of that. Now, the government side, we have many types of clinics, but health clinics, we only, out of the 3,000 over, we only have 1,000 plus health clinics. Clinic kesihatan. And out of all the clinic kesihatan, we have types 1, 2, 3, 4, 5, 6, 7, okay? And the different types have different scopes, different services that can be provided. Types 1 to 3 are the larger ones. They are usually urban. They are the ones that are led usually by a family medical specialist or a medical officer, and they have pharmacy, laboratory, and radiology support, and they can provide comprehensive primary care services. Okay? The others, not so. Now, at the moment, our physical access to services is good. Research has shown about 70% of the Malaysian population lives within 30 minutes driving time of a type 1 to 3 clinic. Of course, some states have lower levels of access, and these would be Kelantan, Terengganu, Sarawak, Sabah, and Pahang. Physical access for the majority of the population is particularly good for maternal and child health services and general acute hospital services. And this is a historical reason, as Dr. Chan has explained, because our health services have historically been focused on maternal and child health. So now we find that there are gaps, especially for the more advanced services required to treat the rising tide of NCDs and their complications, and particularly in less densely populated areas. Okay. Now, it must be said that the Ministry of Health has been restructuring the public sector in primary care. Okay. I think for the past 2 or 3 decades already, the 7th Malaysia Plan, they established a new primary health care division. They have reorganized the health services and trying to move from the silos of the past to a more integrated system that Debbie was talking about. And importantly, they have created positions for the family medicine specialists to provide leadership in upgrading the quality of primary care services, and competencies for allied health professionals, nurses, medical assistants have also been upgraded in terms of training and qualifications. However, the upgrading expansion is slow. Okay, all the clinic kesihatan that needs to be upgraded is very slow because why? Of course, due to lack of financial and human resources. And this is where we see the real lack of budget allocation. Okay. So, what about the private sector? Now, according to Health Facts 2024, in 2023, over 3,000, as I said, over 3,000 government clinics, of which over 1,000 health clinics, right? Types 1 to 7, so 1 to 3, even fewer. On the other hand, we have 10,495 private medical clinics. Of course, this includes both specialist and GP clinics. We don't know the breakdown. I can't find any figures of the breakdown recently, but in 2014, it was reported that facilities as percentage of all clinics, 70% are of the private sector clinics are GP clinics. 70% of all clinics are GP clinics. So if you calculate that, that's about 7,000. Okay. So in terms of current situation, the public, this is the outpatient visits to clinics per capita per annum. So this graph essentially shows how the private sector has grown from the 1950s, 60s until now. Okay. Now, the top 3 reasons for encounters. So at the moment, the current situation, the public utilizes primary care clinics in the private sector for things like fever, cough, runny nose, acute conditions. Whereas the NCDs are being seen in public sector primary care clinics. The hypertension, the diabetes, the lipid disorder, they're all being are the major health problems seen at the public sector clinic. So, private sector clinics. GPs, let's focus on the GPs. What are their problems? They first face competition. First of all, from the public sector clinics, which has come into the urban areas, which started with the One Malaysia clinics, and then with the change of government, of course, they changed the name and all that. Then they are facing competition from specialist clinics, because if people are walking into specialist clinics instead of going to GPs first. And also pharmacies. So you go to any pharmacy, you see people, if you are lining up to buy medication and you have to, see the pharmacist, you will be very frustrated, because the person ahead of you will be getting advice and prescription advice from the pharmacy. Okay, so these are competitions faced. And then secondly, payment by fee. Our current payment system is fee for service. So the fee schedule that is controlled by government for the GP is very low. And recently it was adjusted for inflation, but it was not adjusted for inflation for a very long time before that. And so for the many GPs, the fee is so low that it's not financially sustainable for them. They rely on sale of medications to maintain financial viability. So in other words, they are doing the work of pharmacies as well. And I think the government tried to separate them, but faced a lot of resistance, and understandably so. And now they are also facing a lot of problems and restrictions by third-party administrators that work for employers. So from the policy viewpoint then, obstacles to having a quality primary care and continuity of care in the GP system, what are they? Primarily, the payment system does not incentivize time and effort to put into health promotion by the GPs, number one. Number two, they don't have integrated information system for continuity of care. And also there's no referral system. People can jump everywhere to different doctors, to specialist clinics and all that. And the prescription and dispensing roles of the GP conflict. So Dr. Chan also mentioned we put some proposals. Actually, we put 3 proposals only, 3 priority proposals for the health white paper in July 2022. The first one was what Dr. Chan talked about, increase government funding of the health sector. The second priority proposal that we proposed for this white paper is to strengthen primary care by establishing a family doctor system, which includes both the 3,000 over government clinics, and even if all clinics are upgraded to provide comprehensive care services, they are at the moment only about 3,000 plus. So you have to include the 7,000 over GP clinics. And a truly national effort should mobilize the resources of the more than 7,000 GP clinics in the country. So this family doctor system that we visualize, that we envision, should be one where individuals can be followed by the same doctor or the same practice, for continuity of care. And how can we do that? We can do that by incorporating GPs into the public health services. And we should do that under the capitation system of payment. Why do we recommend capitation system? Because a capitation payment system will, quote unquote, in a way, guarantee patients for GPs. Number two, it can be used to incentivize doctors to keep their patients healthy and discourage from over-medicating patients. For example, you can give regular bonuses, to encourage regular medical screening for patients. Tax incentives can be given to those who serve in rural areas. And incentives can also be provided for GPs to undertake family medicine specialization. From the patient's point of view, you are getting free medical care at the point of service in exchange for tying yourself, quote unquote, to a doctor or a group practice. Actually, we already have the beginnings of this in the PECA B40 system. We already have something in place. We are not starting from scratch. So, if I'm not mistaken, Selangor started with Scheme Peduli Sehat in 2017, giving allocation to B40 people over 50 years old to see their GPs. Okay, 2019, federal government started PECA B40, and this includes free health screening at registered government or private clinics for diabetes, high cholesterol, and kidney function, medical equipment aid worth up to 20,000 ringgit if you need complicated treatment at MOH hospitals. Incentive, they give you incentive up to, I think it's up to, not quite sure the amount of money, but incentives to complete cancer treatment and transport incentives for travel, to the Ministry of Health hospitals. This is very important because even it was started in 2019, in 2022 it was reported only 20% eligible people have taken up this offer. So beginning with this system, we can work on it. You have to work on it to make people take it up. You can expand the system's coverage and scope, restructure the payment system to capitation for long-term care, and your needs, and you need to increase budget allocation for all this. Why capitation is important? Why you have to restructure the payment system to capitation? Why this is important? I think if you have been following the news, a couple of years ago, or even last year, there were reports about scandals of GPs abusing this system by claiming for patients that don't exist, or or patients who didn't receive the screening, but actually they claim for it. So this kind of thing is done because it's very short term. You can do that. But if you do a proper capitation system over a long-term period, I think these kinds of abuses can be less. And more budget allocation is needed. The Harvard study and international comparisons shows that Malaysia spends a high proportion of its health resources on secondary and tertiary health care, 49%. Very low percent on primary care, 17%, and very, very little on long-term care. And this of course, this shows total health expenditure. And actually, to be fair, most of the increases in this secondary and tertiary care expenditure has been in the private sector, has been in the sector of private hospitals and specialists. So I think I end this here. We must act before it's too late. This is a slide I use for its sensational effect, a top MOH official saying too many sick people reaching us, and public healthcare is reaching the end of capacity. You have to do something about it. Of course, the solution proposed here is Kuljit Singh, who represents the hospital sector. So don't look at the picture, just look at the... And these are the references I use, okay? Thank you.
Thank you. Yes, please, sir. Go ahead.
Okay. Hi, this is Raymond again. Quick question to both. Thank
Can
you for...
introduce yourself?
my name is Raymond from Private Digital Health segment.
Okay.
Just a quick question to both. Very
Both.
good, insightful presentation. In your opinion, we talk about capitation model, which incorporating value-based healthcare elements, right? What are the strategic actions that needs to be taken in order for us to move towards the capitation model in view of the current dual payment system in Malaysia? So of course, benchmarking or referencing other countries which actually practicing capitation model. So what are the strategic actions that need to be taken? Some tangible actions, right? So we have been talking about value-based, talking about capitations, but what are the strategic actions needed to be taken care of, especially looking after the primary care sectors and and the whole environment? Thank you.
Thank you, Raymond. May I invite Dr. Chan first? Maybe
I'm so sorry,
sorry.
Prof. Sorry, can I just ask before you address that? I don't come from a health background. Can you explain what capitation means?
Right. Okay.
Thank
So
you.
that's a good one. Yeah. Maybe Dr. Chee, you want to start it, and then maybe Dr. Chan can talk about the financing method. Go ahead. So the question is, what is capitation and strategy actions?
Yeah, actually, a capitation system is a good example is the NHS in UK. Capitation system is a system where general practitioners contracts with the National Health Service. So the National Health Service has a contract with either a group practice or GP to provide healthcare for a designated number of patients who are registered with that GP. So the patient catchment should be more or less stable lah. Of course, there are movements here and there, and for the services that are provided by the GPs to these patients is essentially paid for by the health service.
Does that answer your question? Maybe, Debbie. Yes, please go ahead.
If I can just... so capitation actually just means that you pay on a per person basis. So there are different ways of structuring capitation, but a capitation payment system means that you pay for a certain package of services to be delivered on a per person basis. So that can be a catchment population. So you can have a population, what we call population-based capitation. So if you're in a very stable population where you've got, one clinic for this sub-district, for example, in a country, then capitation can be that population, but then you have all of the cross-border issues. What often happens more is that, and it's really this mechanism to try and create competition as well between primary care providers. You'll have a system that's called empanelment, which is where a person will register with one, and in some countries it can be up to 3, so it doesn't only have to be one. will register with a primary care provider, and then they will be paid based on the number of people registered with them. So the literal capitation payment is just that you're paid on a per person basis, per capita, hence capitation. But then, so that has a lot of good incentives in it. What it doesn't do, you can imagine, like if you just got paid per capita and then you got to keep whatever you didn't spend, which is often what happens, then there's incentives to under-provide care. So if I just get, okay, all these people have registered with me, but I get to keep whatever I haven't spent, which is why we usually say that we work on the basis of a performance-based capitation as well, where we have certain indicators in there that say, okay, you also need to achieve these targets, etc., as part of the capitation basis. Okay, sorry if that's okay.
Yeah, thank you, Debbie. At the moment, we don't have it for the national level. We don't have it yet. Most of our so-called GPs are paid either by person. So the PERCA B40 sort of, tried to sort of facilitate that, but it's still covered by the government. And that's not, in a way, it's not even per GP. It's based on their, sort of reimbursement by the provider, which is the GP, the private GP here. Can I pass to Dr. Chan if you want to touch on Raymond's question just now?
Yeah, let me touch on the aspect of family medicine. Okay, I think you may or may not agree with this. Okay, but perhaps there needs to be some degree of upskilling. Okay, of family medicine. Okay, practice. Okay, now I was teaching at UM. Okay, in the medical faculty until 2016. Okay. And as of that time, okay, the impression I got from my colleagues, okay, in the department of SPM, okay, was that the numbers of family medicine specialists, okay, in KKM, okay, was very low, okay, in contrast to MOs, okay, MOs without further training, upskilling, okay, in family medicine, okay. So that's one issue, okay. The Chee Heng Leng presented some figures, okay. So the numbers of family medicine specialists, okay, are inadequate, okay, for proper primary care, okay. Notwithstanding that, the Harvard consultants again in the reports again mentioned clinical audit again. I don't know whether it was randomly selected, but they did a comparison again of primary care practice again in the private sector again with KKM again primary care. And I think, although I'm not sure, okay, that the ones that selected from KKM were actually the family medicine specialist again. So perhaps not surprisingly, again, they found that actually the KKM primary care doctors outperformed again the GP primary care providers, okay, which were who were selected again in terms of accuracy and diagnosis, medications, okay, medication regimens, etc. Okay. So, so there's an issue of increasing the number of family medicine specialists in KKM, as well as upskilling again the average level okay, of GP practice, okay, primary care in the GP sector. Okay. Now, added to that, and this is anecdotal, okay, perhaps you can share from your own experience okay, in the private sector. Okay. I'm told that in some of the major urban centers, KL, maybe Penang, JB, okay, that if you wanted a location of your practice, okay, in urban areas, it's very expensive, okay, right, to rent or let alone to purchase, okay, a locale, okay, where you can set up your practice, okay. So in fact, many younger primary care providers are going to come out in the private sector find it very difficult, okay. Now, I don't know whether that's leading to a situation in which they actually are quite inclined, okay, to serve in KKM again as medical officers again. But in fact, we've heard again that that is getting increasingly difficult getting permanent positions again in KKM again. So so I don't know whether that might in time again sort of lessen the problems of the preponderance again of primary care providers being in the private sector again rather than in KKM as salaried staff again. But also, of course, that means you also have to upgrade the quality of care again in KKM primary care. Yeah.
Thank you. Debbie, you want to add something On the process.
Yeah, just to go to your question about some of the things. So you specifically are talking about a transition to capitation. So two of the earliest things that need to happen. So one is universal in any country is the first thing that you need to do, because to develop that rate, the per person rate, you need to know what services that you want to ensure is delivered and financed under that system. So you first of all generally define a primary healthcare package that you want that capitation to be able to finance, and you cost that package. So that's the first thing. And you look at differentials in that cost based on like demographics. So for an older person, generally we know like women of reproductive age, children, older people, all of that uses more healthcare. So we make adjustments for those kind of things. So that sort of costing, that package definition and the costing and the adjustments. The other side of the coin that's always necessary is public financial management changes. So at the moment, we've got a line item based system of paying, for example, the Klinik Kesehatan. Might be different when you're contracting. That's easier in terms of the GPs, but it's really important for the public sector as well. So the public financial management, there's a lot of negotiations in any country shifting to capitation that go on between Ministry of Health and Ministry of Finance usually to say, okay, can we shift from line item budgets or, shifting from fee for service even, but shifting from line item budgeting where you generally have much more control over what happens to then a capitation system. All of those negotiations are really high priority as well because that takes time.
Thanks. Can I quickly
May
respond?
I just want to add that one of the most important steps in transitioning is talking to the GPs, and getting their buy-in. In a way, you have to start that process very early and bring them along.
Yeah, sorry, I should quickly respond to that before Dr. Arasu. I totally agree. And I think the key thing is the alignment, right? Public and the private side on the GP, the interest alignment, the incentive alignment in order for the buy-ins, as well as the literacy and also the policy, whether are we having the, very strong political drive towards this new capitation model while we have been doing decades of, FFS, right? So it's not easy. I mean, it's good to learn from other countries. How do they transition from that model? Like Indonesia is doing it, right? The capitation model, and having some success. But of course, there are also a lot of challenges. So something that we can learn, and which is also need to localize to our Malaysian population and the system as well. Yeah.
Just because I used to work in Indonesia. And so just to be clear, a lot of the countries that have done it have started with public sector. So Indonesia, in that case, the capitation was done with the Puskesmas, largely first. Mongolia has one of the best performance-based capitation systems around, also largely with the public sector, but now public and private. So there's also issues with that completely.
Yes, please go ahead.
Just
Dato', go ahead.
I'm also a practicing GP. So I've done quite a number of studies, especially on GP demographics in the country. I think we've done the largest study in 2017, and it was published in the International Public Health Journal. It's on GP demographic. Okay, basically, number one, I think what Dr. Chan mentioned earlier is the Colico-PC studies. So Colico-PC study is the one that compared the performance of GPs and also the KKM, MOH clinics. Actually, the percentage difference is very, very small. It's less than 2%. And then we must also know GPs see more acute cases compared to Klinik Kesehatan, where they see more NCD cases purely because of economic reasons. Because who comes to the GP clinics are M40s and mostly B40s. Top 20 goes to the private specialists. Okay, the other thing is that why the GPs do not do specialization, there's no incentive. Because if you become a specialist, GP specialist, immediately you go under NSR, National Specialist Registry. Then automatically you go under the 13th fee schedule. So for the 13th fee schedule, for the specialist rate is that a consultation is 80 to 235 ringgit. So now the employees and the payers, they wouldn't want to pay 235 ringgit to see a GP specialist when they say, hey, I would rather see ENT, I better go and see an ENT specialist. A pediatric, I go and see a pediatric specialist. So definitely there is an issue of policy of which the government has to address. And second thing, if you look at the governance structure of the KKM itself, you have DG, you have deputy DGs. Now you have 4 deputy DGs. So the 3 deputy DGs, one is technical and scientific research, and you have one is Perubatan and one is public health. So currently under the public health as well, BPKK is there, Bahagian Perkembangan Kesihatan Keluarga is there. All this while, the head used to be a public health specialist. For the first time, they're having a FMS who is the head there, which is very good. But you have the Perubatan where you have Perkembangan Perubatan and then CCAPs. So they are the one actively regulating and micromanaging the GPs, but they're also supposed to perkembangkan. So the perkembangkan is only for the government sector. They do not perkembangkan the private sector. Okay, so there's an anomaly in the structure of which we have been talking about that. We were hoping that the health white paper would address it. Just a context to say why we are in this situation. And then there are multiple issues to be resolved. I mean, since the media is here, because we need all your help to actually put the pressure on the government and also educate the public where are the gaps and how can we improve with that. And the last one is that Dr. Chee Heng Leng, actually almost I can say 90% of the clinics are GP clinics in the country. From the currently as at May, we have 11,490 GP clinics in the medical clinics. We can comfortably say 90% of them are GP clinics. The private specialist clinics are not many, except for those who are some, for example, the older way of a private hospital like Gleneagles and probably some Damansara and some Makota Hospital where the private specialists can buy the suit. They register under, those numbers are no more increasing. So those coming out to open in silo, also very little. So I could comfortably tell that 90% the thing is there. It's in the public domain. The data is there. Unfortunately, you have to go through the Excel file and then for the 11,000 clinics, you got to filter it one by one to get the number. Thank you.
Thank you, Dato'. Yes. All right. Yeah, go ahead.
I don't know whether this is still pertinent, okay, but back in the early 1990s, okay, Tan Sri Baka, okay, together with Dr. Jai Mohan, okay, and there was a Chinese lady pediatrician, okay, but the 3 of them carried out a study, okay, on behalf of Academy of Medicine, okay. No, it wasn't one, it was another. Anyway, comparing outpatient specialist clinic in the private sector and in the government sector, okay, and they found that not surprisingly, in the government sector, okay, outpatient specialist clinic, okay, saw mainly complicated cases because there's a gatekeeping referral from MO, okay. But in the case of private sector, okay, 3 out of 4, okay, of outpatient private specialists encounter, okay, in outpatient clinic, okay, were for conditions, quote unquote, trivial conditions which should be easily handled by a well-trained primary care practitioner. So, because of the lack of gatekeeping, okay, and referral system, okay. So in other words, it was they had spare time, okay, from other than dealing with the specialties, okay, but they were seeing primary care patients, okay, 3 out of 4 patients, okay, for relatively simple trivial conditions, okay. So I think this is an issue which presumably some kind of health financing system, okay, might try to address, okay, the underutilization, okay, of specialist expertise in the private sector to the point that they are actually spending time doing primary care, which can actually be handled by a well-trained primary care provider.
Yeah, I think the groundwork, I think Raymond is already done by many sectors on the costing and things like that. But it has the second part of what Debbie mentioned is probably still not happened yet, the political drive and things like that. The costing part on different benefit packages for outpatient and things like that, I think the cost is available from the public sector. Definitely some work probably needed for the private sector. I think the data is probably there as well. Yep. Okay, we don't have much time. Can I invite anyone else to present any questions to the speakers? Yes, please go ahead. Thank you.
Hello. Hi, my name is Lishan and I'm a lived experience advocate for mental health. My question is, the large question is, how might communities work more with primary care providers to, quote unquote, prevent diseases, including mental health issues? More specifically, I was thinking about like the referral system from community to primary care in terms of like maybe social workers who are house visiting, things like that. So this thing occurred to me, which is, are there actually, and my question might be coming from a place of ignorance, are there referrals from GPs to, say, community groups? For example, a GP could refer a patient to a running club or like a nature group that goes on nature walks, something like that. I think there are sort of a lot of discussion about like prescriptions for such treatments, but those prescriptions are to like individual patients, I guess, rather than bringing them back into the community. So yeah. So my question is, is there actually already this sort of bi-directional referral system in place, or could such a thing be implemented, and just throwing it out? Thank you.
Thank you, Chan. Yes. Anyone? On mental health and community work and mental health, that's the first part. And the second part is that how often or how applicable is the referral, especially for CSOs and NGOs related with this matter?
I'm afraid I do not know very much about mental health at all, so I really cannot answer that question. In terms of generally whether GPs, try to do health promotion, I think I came across in one of the studies that they do try to do that within their own limitations, within the limitations that they have. But I don't know, do you?
Yeah, Dr.
Can you
Chan,
answer that?
Dr. Chan, you want to carry on with the answer? I think
I
Dato'
can't think
want to
of
say as well.
any instance offhand. I can't think of any.
Yes, Dato', yes. Go
Thank
ahead.
you.
Very good question. Okay, let me speak first on the mental health. Actually, GPs, we do see lots of mental health cases, especially it's more prominent after the COVID-19. Okay, common symptoms are headache, repeated headache. When you ask a little bit extra question, then you'll understand they're having mental health issues, and many of them are minor one. So what MMA we have done is that knowing the issue of mental health, and GPs in a very good position actually as a first point of contact and close to the family, because we have done a study to show that based on the Qualico PC, a patient we see the outpatient 3.9 times in a year. So if you have a family of 4 in a GP clinic, they'll come with a wife, they'll come with a, so you can see they visit at least 10 times, maybe 4 times for treatment, another 8 times to accompany somebody. Okay, so based on this, we said we are better positioned. So we have actually approached Ministry of Health. Actually, we have done a paper, not paper, it's all submitted to the ministry and then also approved, whereby we will train GPs for GP special interest in mental health management, very basic things. Okay, then we have also, we have put it to the minister, also approved. So now it's a paperwork in progress, so they'll be able to train more GPs who have interest in mental health, and then they can provide as a gatekeeper in managing that. And your second question in terms of prescription, of course, as a GP myself, I would say most of my colleagues, we do promote, because nowadays we know in every community in the Taman in Malaysia, you have lots of activities, either Tai Chi or hiking, all kind of activities, right? We do encourage them. Even though there's no formal structured way of referrals, but even these programs are done all in a very loose form, right? Somebody takes the ownership. So we do refer them, hey, why don't you join this group? Because GP is community-based. And most of our patients, 80% of patients are within the radius of less than 2 kilometers. So we know roughly where they're coming from. So this is what we do. And then, so these are the things, the referrals. So the system is already in place. Is that how do we, like what our Chan said earlier, how do we put a system, the basic thing what the government should do, which MMA also has proposed to them, that link the GPs with the clinic kesihatan and the government hospitals. So these are the basic things which doesn't have cost to the government, just to link a simple referral whereby you create a WhatsApp group between the GPs in that area with the clinic kesihatan, with the emergency department. Has it been done? Yes. There's one hospital in Ishta, the ED physician that has been doing that for so many years, where he connected all the GPs in that area with the emergency department or Ishta. Any referrals, they can communicate directly. So that actually solves problem at zero cost. So these are the simple things actually government can do to create the network of GPs with the clinic kesihatan first and the hospital. There is some communication. So by doing that, like what Dr. Chan said, of course, currently there is no standard of care the same everywhere because there's no formal training for you to become a GP. So many of them, they go for courses on their own, right? So by doing this, you can also elevate the level of care because now you're communicating with somebody. So for a program for the mental health, so one of the proposals we told them is that, like in the 4C just now, right, you must have continuity of care. When you refer somebody, you must know what's happening to the person. Then you close the loop. So these are all in progress. So of course, with the political will, we hope to see that is being executed, not just keep talking.
Thank you. Yes, Debbie.
Just to make a quick comment, and you probably know this better than me, and I wish Isaac was here. So WHO has a mental health person as part of the WHO team who's Malaysian, Isaac, in the team. But so I know that the Ministry of Health have the Mentari centres, which are the community mental health centres as well, and they're aiming to scale those up further. Definitely, as we're looking at allied health, one of the challenges is in terms of particularly clinical psychologists. So in public sector, the mental health is quite psychiatrist driven, and so that availability of clinical psychologist at one stage and then counsellor for those ongoing support, and then obviously also the regulation of the social worker as well. So there's a few things there that I think in terms of the personnel to deliver, and I'm not disagreeing with the GP and the training, but in terms of some of those specific skills as well around mental health support, I think that availability of community mental health services, and you probably know that WHO has the MH GAP, which is the Community Mental Health GAP Action Plan. Those are things that definitely I think would be high priority to look at, not just for Malaysia, but for a lot of countries. So definitely the allied health services to support those mental health service delivery as well is really important.
Thank you, Debbie. I think mental health is a very big thing now, especially after COVID, and you have the possible effect of the long COVID as well. Just before that, maybe can I invite someone from Ministry of Health who has been here? Doctor at the back, yes. Can you touch on the services that's provided by the public sector, which is a lot on mental health? Yes. Betul? Tolong. Any one of you? Can you talk on coming from the Ministry of Health?
Hi everyone, my name is Dr. Arif. I'm coming here as an NGOs, but I'm also working in Ministry of Health. Basically, under Ministry of Health, we have what we call NCHEM, National Center of Excellence for Mental Health. So their role is basically to provide the policy on mental health, to provide the service in any facilities under the hospital or also KK lah, klinik kesihatan. So regarding the service between private and also government, basically we have such connection between them. It's just that we lack in promotion to the communities. I think this is the important thing that government needs to do to promote the service provided by the government. Of course, this thing must be highlighted by public health, because clinics, actually the service governed by the public health in Ministry of Health. So that's the thing that I can share for the time being.
Thank you, Dr. Arif. So does that answer your question, Chan? Somewhat, from the public and private sectors.
Yes, thank you very
Thank
much.
you. Yeah.
Sorry, can I just
okay.
add on to Dr. Afif, okay? Dr. Afif. I think Arif, yeah. Aside from being KKM staff member, I think you're also with Ikram, right?
Yes, correct.
Yes, and actually, as in the earlier conversation, it occurred to me that one of the institutions which are naturally, could be quite relevant, okay, to such initiatives. There might be some of the faith organizations, okay. Yeah, I'm thinking, for instance, okay, of some friends and relatives of mine who are church members, for instance, okay, and some of them are medically trained, okay, who are involved in medical missions, okay, domestically as well, in certain cases abroad, okay. So they go into orang asli villages, for instance, okay, to provide various kinds of care, okay. And so those doctors or other health personnel, okay, within such faith organizations, like Christian, Islam, Muslim, or other faith organizations, okay, might be able to bridge that kind of gap, okay, between the conventional health professional, okay, and other kinds of community-oriented services, okay, both in mental and non-mental health areas. So, could you tell us a bit more about what IKRAM might be doing, okay, in this regard? Okay?
Okay. Basically, IKRAM is an NGO, a big NGO. Under IKRAM, there is a wing for medical background. It's not just a doctor. It also included allied health. So that's we call IKRAM Health. So basically, IKRAM Health, for now, we are focusing more on reaching communities to increase health literacy, such as we actively teach community on CPR, and also we actively do health screening for the B40s, and also we have some like follow up for them once we do the screening. And this the thing that we do currently, because we also have limited numbers, those doctors and allied health that can do the volunteerism activities among IKRAM. So that's the idea of IKRAM Health.
Thank you so much, Dr. Chan, Dr. Chee, and also Dr. Arif, and of course, Debbie and Dato'. So we have finished our Q&A session, and I pass back the mic to our Madam MC. Sorry. Yes.